right, so we're going to finish up our presentation here talking about other causes of altered mental status that you can see. They include dizziness and syncope. Syncope is just another name for fainting. So if you have a patient that has a syncopal episode, that means that they passed out. Most of the time when a patient has a syncopal episode, as soon as they get horizontal, they begin to wake up. Another phrase that you need to be familiar with is the near syncopal episode, which means the patient gets really, really dizzy, but they don't pass out. They sit down, they get to feeling better, and there can be a number of causes of these. Dizziness and syncope can be indicators of serious or even life-threatening diseases. You may not be able to diagnose the cause of syncope, and that'll be true for both you and I as paramedics. However, it's critical that you use your assessment to rapidly identify and treat life threats and to gather information that will assist the treatment of your patient. Dizziness and syncope are separate problems, but they are often related. During your assessment, find out what a patient means by dizzy. So ask them open-ended questions that will help them to be able to identify what's going on within them so that when they say dizzy, they can explain to you exactly what's going on. Now, as I said earlier, syncope is a brief loss of consciousness with spontaneous recovery. And this often occurs really, really quickly as soon as the patient gets horizontal and we have increased blood flow that returns back to the brain. The patient may have a warning sign that a syncopal episode or a fainting spell is about to occur, and this may result in or come about as in lightheadedness, dizziness, maybe their vision gets blurry or even darked out, or they may become diaphoretic and begin to sweat. Occasionally, your patients will also be incontinent bowel or bladder, and again, as I've said before, this can be quite embarrassing for your patient. Some of the causes of dizziness or syncope include cardiovascular causes. They can be either the heart beating too fast or beating too slow. When a person has increased pressure in their chest, so they're bearing down, we have a nerve, as you learned in cardiology, the vagus nerve, VAGUS, that runs through the heart. And when we put pressure in the chest or in the heart itself, it puts pressure on the vagus nerve and it secretes a specific neurotransmitter that slows the heart rate down. And so whenever a person is suddenly frightened or put under significant emotional stress, they can begin to breathe really fast and increase that pressure in their chest. And this is known as a vasovagal syncope. Vaso meaning vascular, vagal referring to the vagus nerve, and resulting in a syncopal episode or your patient passes out because their heart rate drops down to too slow. There are hypovolemic causes of where your patient would have low fluid or blood volume, such as when you would have a patient that's dehydrated as a result of severe heat exhaustion or really massive diarrhea accompanied by vomiting. They could be having internal bleeding, such as you would see in a female who would have a ruptured ectopic pregnancy. Maybe they'll have slow bleeding from an aortic aneurysm, or they potentially have an ulcer in their stomach or in their intestinal tract that results in either slow or fast bleeding. Traumatic causes and metabolic causes, as well as structural causes, means that there's something wrong with the brain and the structures that are near it. And some of the metabolic causes that we could see would be hypoglycemia, having a patient with a blood sugar that's too low. And remember, with hypoglycemia, that is a sudden onset. You could have a patient that has an altered mental status because of a high blood sugar as well, hyperglycemia, which comes about as a result of the patient having not enough insulin and that blood sugar building up, leading to dehydration because they'll have massive vomiting accompanied this. Hyperglycemia or diabetic ketoacidosis comes on, takes hours or even days or potentially weeks. Other causes that would be a structural cause of the brain would be a stroke or a seizure for your patient. Now there are some environmental causes that come about here, such as alcohol or drugs that are central nervous system depressants. We see this quite frequently with opioid usage in America today that can cause the patient to become unresponsive. Carbon monoxide poisoning, we'll talk more about this a little bit later on, is a slow, well, I say slow, but it can be rather quickly depending on how much carbon dioxide is being dumped into the atmosphere. And the danger with carbon monoxide poisoning is you can't see it, smell it, or taste it. Other behavioral causes are panic attacks and anxiety attacks that come into play here. Now, the thing to remember, when a patient is having some type of a behavioral emergency, such as a panic attack or an anxiety attack, many times we look down on those people, but understand in America today, and especially with us coming out of COVID, mental health issues are a serious, serious problem. And they're even more serious in the profession that you're going into. Therefore, it's imperative that you show compassion and consideration towards any person that's having some type of a behavioral issue that leads into an altered mental status. In about half of the cases of dizziness or syncope, no cause is ever found, despite being sent to the ER or maybe even going in and dealing with professional specialists. As far as your patient assessment, the secondary assessment for a patient with dizziness or syncope includes getting a really, really good history on your patient, as well as vital signs. And some of the questions that you need to ask are as follows. First of all, have the patient tell you, as I said earlier, what do they mean by dizziness? What exactly is that? Ask them, did you have any warning? Did you feel funny or different before this episode came on? And when did it start? As well as what were the events that led up to it? Find out from your patient if it has not resolved by the time you get on the scene. How long did this episode last? And that leads you to some pretty good information. Finding out what position the patient was in gives you a really, really good idea of kind of what's going on. So if your patient is standing up, there are sometimes we see patients that are in, say, like marching bands or the military, or they're standing up for a graduation or a long period of time, and you have a reduction in the blood that's going from the brain. Finding out that they were standing up and they had this episode is less concerning. Now, don't misunderstand me. It doesn't mean that we're not concerned, but it's less concerning than if this happens while the patient is in a sitting position or in a reclining position. Ask the patient, have you had anything like this that's happened in the past? And if so, was this particular episode similar to it? Find out from them if they were able to identify a cause for what has happened in the past. Try to find out what type of medications that they're on. Now, as an EMT, it's not essential for you to know every single type of medicine that is out there, but it is important for you to know different types of medicines that can lead to altered mental status. Things such as beta blockers, narcotics, blood pressure pills, diuretics. And so begin now when you are taking care of patients and you come across a medication that a patient is on, write that medication down, the name of it down, and then go back and research it as to particularly what is the class and what does it do. Did they have any other signs or symptoms with this? Do they have headache, chest pain, nausea, vomiting? Ask about their bowel movements. Do they look black or tarry? This could be an indicator that your patient has some type of a GI bleed. When the patient does this, now what are we going to do? Well, first of all, if they need oxygen, then we're going to administer oxygen for it. Now, if the patient is unstable, you got a decision to make, okay? If they're unstable, they're going to need advanced life support. So your question that you have to answer, and there's no hard and fast rule for this, is how do I get advanced life support to my patient the quickest? Will it be quicker to take them straight to the hospital? Will it be quicker to wait on the scene for ALS to get there? Or will it be kind of a middle ground of where we meet ALS while we're en route? Loosen the clothing around the neck. This helps the patient to cool off a little bit if they are overheated. It also improves circulation of the brain, and sometimes it can make it easier for your patient to breathe. Put your patient in a nice supine position, watching them closely for the potential that they may vomit. If you have any concerns that your patient is going to vomit, go ahead and get your suction unit out and get it ready so that you can be ahead of that curve so that you can suction your patient right away. And then lastly, if the patient has fallen, treat any kind of injuries that you are going to address and take a look at. So as we finish this out, again, keep in mind that we had done in class the diabetic emergencies. Understand that the diabetic emergencies are usually caused by a patient's ineffective management of the disease process. Now, this could be their fault, or it could not have been their fault. So sometimes patients that are diabetics are doing every single thing that they can do to manage their disease, and yet it's still not managed well. Other times, they're not compliant with their medicine, they're not compliant with what they eat, and it brings us along. It can lead to either a low blood sugar, hypoglycemia, that happens really, really quickly, usually within a matter of minutes, or hyperglycemia that comes about over a period of days or potentially even weeks. Also remember, seizures have a number of causes. When you're looking at this patient and you're assessing them, be concerned about the potential for a spinal injury. Protect their patient's airway and give them oxygen if they need it. Whatever you do, don't restrain your patient while they're having the seizure. Wait till the seizure is over and then begin to treat them. Protect their head, their neck, their extremities during the seizure so that you don't have any additional injuries that go on. Get all the information you can about the time of onset, what the patient was doing, so that you can relay that information to the hospital. A stroke. You have two types of stroke. You have ischemic stroke, which is caused by a blockage. You have a hemorrhagic stroke, which is caused by a rupture of a blood vessel in the brain, and we have bleeding in there. The vast majority of the types of strokes that your patient has are going to be ischemic strokes, and that's a good thing because it can be treated. Hemorrhagic strokes cannot. When you're addressing these strokes, keep in mind that you see the signs and symptoms here. You can have an altered mental status. You will often have numbness or paralysis on one side, facial drooping as well, in addition to difficulty with the speech. And their speech may make no sense whatsoever. It may be completely garbled, or it could potentially be slurred. And then finally, in all your patients with an altered mental status, number one, determine whether you need to give oxygen. And then number two, and again, this is one of the few alls that you're going to see, or always that you're going to see in medicine. Get a blood sugar. Doesn't matter what their chief complaint is. If they have an altered mental status, get a blood sugar on these patients.